Dear colleagues, ladies and gentlemen, welcome to the view from the Thoraxcenter for Radcliffe Cardiology. I am Nicolas van Michem, next to me my good friend and colleague Joost Dame, and this time we are wrapping up the AHA 2024 meeting. It's a little bit of a delayed wrap-up, but still we have some things to discuss about the meeting. So why don't we start, Joost, with the Clear Synergy RCT.
Yeah, so Clear Synergy, as you may recall, is the big randomized controlled trial that Sanjay Jolly from Hamilton recently presented at the TCT meeting. So it's basically a very large-scale randomized control Canadian trial, over 7,000 patients within 72 hours post-acute myocardial infarction, randomized to either placebo or spironolactone, or placebo or colchicine in a 2x2 factorial design. The results for colchicine were presented at the TCT meeting and led to a lot of debate as to the fact that the addition of colchicine post-MI didn't add anything in terms of major adverse cardiovascular events at 1 year. Now at the AHA meeting they presented the results of the randomized comparison of spironolactone versus placebo. And that trial, or that subset of the trial, basically showed the exact same thing. No benefit whatsoever in terms of the primary endpoint of CV death or new or worsening heart failure in patients randomized within 72 hours post-MI to either spironolactone or placebo. A couple of comments. So this trial is a little bit of a successor to the Emphasis HF, which was stopped prematurely due to an overwhelming effect of eplerenone on top of heart failure medications in patients post-MI, but with a reduced ejection fraction. And the Ephesus trial, which was more or less a similar population of patients randomized within 7 days, also highly positive, which led to a recommendation for MRAs in the heart failure guidelines in patients with an ejection fraction below 40%. In that perspective, this trial was different, as this trial basically included all comers post-MI, so not just patients with heart failure, basically everybody post-MI, irrespective of NIA class or ejection fraction, was enrolled.
STEMI and non-STEMI? Both?
No, STEMI only, if I'm correct. And in that perspective, the second difference was the fact that they used spironolactone instead of eplerenone. So that makes me think a little bit as to the fact that eplerenone may be somewhat better agent. But that obviously is not something that this trial investigated. For now, at least no reason to add a MRA routinely in patients post-MI.
Well, at least not post-recent PCI. I think that is one of the major differentiators from Emphasis and Ephesus, right? Because this is somewhat a PCI trial.
That's correct.
What is the optimal medical therapy after PCI? And mind you, also, PCI has evolved over time, and the way we are doing PCI today is so different from the era of Emphasis and Ephesus.
Yeah, these trials were 20 years ago,
exactly.
by the way. So that is absolutely
it's a
nuance that is important.
It's a new world. We are so much better in terms of PCI quality. The drug-eluting stents are a different level. The way we are managing cholesterol and so on, I think that also affects the outcome of these trials, obviously.
Absolutely.
Yeah. All right, so let's move on to the SELECT-CABG trial.
Yeah, SELECT-CABG is a trial that we discussed in a preview, so please recall SELECT, which was the 17,000 patient randomized controlled trial that was presented at AHA last year. A trial that assessed the effect of once-weekly semaglutide compared to placebo in patients with overweight or obesity, but without diabetes. Adding semaglutide resulted in a 20% reduction in MACE in this, let's say, virtually very broad patient population. But this specific trial of this relatively expensive drug that is quite hyped over the past years is what was studied in a predefined subgroup analysis of patients post-CABG. So we were wondering a little bit why post-CABG, but if you read the paper and the abstract, the concept is basically, which makes a lot of sense, that this population represents patients with a very high or extreme atherosclerotic cardiovascular disease risk. So what this subgroup analysis aimed to assess was first whether patients post-CABG had higher event rates, which makes it's a little bit of an open door, and that's also what the trials showed. Patients post-CABG have higher event rates versus those who were not post-CABG. But more importantly, the intention was to assess the treatment effect of semaglutide versus placebo in patients with and without a history of CABG. And what appeared to be the case is that semaglutide was effective in both cohorts, both those with post-CABG as those without previous CABG. But in patients post-CABG, that the treatment effect, if any, was even larger as compared to the ones without a history of CABG. So that, I think, is a very important finding. And makes to me that and illustrates the potential value of adding semaglutide to obese patients at high cardiovascular risk, given the fact that this is quite an expensive drug that we will likely not be able to administer to everybody. But in these particular patients, there may be additional reason to provide them with this drug in case they are overweight or obese.
An intriguing analysis, and you might speculate that patients with CABG arguably have more extensive coronary artery disease, right? The majority will have 2 or 3 vessel disease, otherwise they would have received a PCI. So absolutely. I think there is more to win in those patients, probably with more aggressive therapies to control cholesterol, but also to control overweight and diabetes. So it makes sense to me. It's a good study. Study. There was also another study in patients with obesity. That was the SUMMIT trial. The SUMMIT trial in HFpEF patients with obesity. It is a randomized controlled placebo-controlled trial, a phase 3 study, looking at the value of tirzepatide. This is another glucagon-like peptide receptor agonist, but unlike semaglutide, it also activates the hormone glucose-dependent insulinotropic polypeptide, GIP. The study started in 2020, 731 patients, the mean age of 65 years old, almost 50% men and women with a BMI of 38. So definitely morbidly obese patients with symptomatic stable heart failure defined by a New York Heart Class 2 to 4 and a left ventricular ejection fraction above 50%. So in keeping with what we know and understand under HFpEF. Patients had an elevated NT-proBNP. Their body mass index had to be above 30 kilograms per meter squared. And the primary endpoint was in favor of the treatment therapy with tirzepatide. So there was a bigger change in the KCCQ. So the KCCQ improved more, 7 percentage points more in the treatment arm versus the placebo. And also the occurrence of the composite endpoint of cardiovascular death and or heart failure events over time showed a 38% relative risk reduction from 15% to under 10% in favor of the treatment arm. I think this was all driven by the heart failure events, but still significant and I think clinically meaningful. So I do believe that even though these therapies are still quite extensive, there is a need for those therapies.
Yeah, absolutely.
Yeah. What about Yellow 3?
Yeah, Yellow 3 is a much larger trial actually, but I think interesting because it is a little bit in the concept of finding the optimal patient population that could benefit from new pharmacological agents. And that is also what Yellow 3 sub-analysis, this Yellow 3 sub-analysis presented by Annapurna Kini tried to aim for. So the study actually looked for transcriptomic signatures and predictors of evolocumab added to high-intensity statins therapy on intracoronary plaque characteristics. So basically what happened is that Yellow 3 included 137 patients with chronic coronary syndrome and intermediate lesions that underwent multimodality imaging at baseline and 26 weeks to assess the added value on plaque progression or plaque stabilization, so to speak, in patients on evolocumab versus placebo on top of high-intensity statins. And what they found is that, in line with Glagov and the Huygens trial, that was indeed the case, as we also found in Pac-Man for alirocumab. But interestingly, in 24% of the patients, no response was found if you looked at lipidic plaque load. And the reason is, why is that? And that is what they tried to look for in a subgroup of this patient of 104 patients. That actually underwent quite extensive peripheral blood mononuclear cell assessment at baseline and follow-up. So they used quite a complicated model of machine learning to find specific genes and models that could be predictive or could be specific to identify those patients that did not respond to this plaque progression. And what appeared that it is likely one of the most important genes was interleukin-10, which is something that we've heard more often in the most recent studies, that could have a specific role in identifying those patients in terms of treatment effect. So of course this is a really exploratory analysis of something that is quite novel, but to me it's interesting because it could be a small step forward into a way of finding patients that could really benefit from these expensive treatments. And yeah, benefit the most versus those who are upfront less likely to benefit from these treatments.
Now, this is for the more advanced people, right?
Absolutely, it's more academic.
Yeah,
but I think it's interesting.
Yeah, for sure. An interesting analysis also in patients with aortic stenosis. As we know, the elderly patients often have cardiac amyloidosis in combination with aortic stenosis. And there was an international registry that presented 266 patients with dual pathology. So they had moderate to severe aortic stenosis in combination with a proven cardiac amyloidosis. And they were then also compared to a matched cohort of patients with lone aortic stenosis who received aortic valve replacement. In the 266 patients, not all the patients received valve replacement. So 70% received a TAVI, 4% only a surgery, and 1 in 4 did not receive any valve replacement. So an interesting set of patients. Mean age was 85 years old, 80% were male, and only 30% received treatment with an ATTR-specific agent, predominantly tafamidis. There was a very high mortality, 50% mortality at 3.6 years with heart failure hospitalization in a quarter of the patients. So very sick patients with relatively poor prognosis. Turns out that, and I was not surprised, that the ATTR-specific medication significantly improved survival in the patients with this dual phenotype of aortic stenosis in combination with cardiac amyloidosis. There was a more than 50% relative risk reduction, emphasizing the role of amyloidosis treatment in patients with aortic stenosis. And this is definitely not routine clinical practice. We must get better in identifying the patients with concomitant amyloidosis and aortic stenosis. And we also are heart failure docs, and we have a group of physicians that are focusing on HOCM and hypertrophic cardiomyopathy, but also on cardiac amyloidosis, and they have a clear interest in this topic, so we need more collaborations in that direction. It was also interesting when we looked at the matched analysis with the patients who had lone aortic stenosis and get a valve replacement. It was only the group with the combination of aortic valve replacement and tafamidis treatment that did as well as the control arm. Otherwise, the patients with cardiac amyloidosis had a worse prognosis. So definitely there is something there. We need to get better. And then there was also the AMPLATZER IDE LAA trial. We are very familiar. We have been discussing this trial multiple times at previous meetings. This time, the 5-year outcome data was presented. We're talking about a significant trial of more than 1,800 patients with a mean CHEST-VASc of more than 4.5. The mean age of the patient, 75 years old, 60% male. And patients were randomized to an LAA closure with either the Amulet device or the AMPLATZER. Well, at 5 years, no surprise, there was no difference in the major outcome. If you look at stroke, if you look at mortality, also no difference in bleeding, although there were less patients in the Amulet arm that still were on a NOAC or anticoagulant drug therapy, whatever that means. I mean, once you close the LAA, basically they can take you off your NOAC or OAC therapy. So, but there were more patients with a Watchman device that were still on a NOAC than with the Amulet. And also of interest, we are talking about a patient at a very high risk for a stroke. CHEST-VASc of 4.5 or more than 4.5. The annular stroke rate was only 1.6%, and more than 90% of the patients were off antithrombotic therapy. So this is quite a strong argument in favor, or at least for the consideration of LAA closure, transcatheter LAA closure. And whether there's a big difference between the two devices, well, there seems to be a better sealing and less thrombosis with the amulet over the Watchman, but I think it did not translate into any clinical benefit. So I think my conclusion here is LAA closure, a transcatheter LAA closure, it works, and it might be a therapy to consider, maybe predominantly in the patients who have issues facing oral anticoagulant drug therapy, but at least it is still amazing to us that there is no reimbursement for this this kind of therapy in the Netherlands. So hopefully that will change in the future. We already mentioned cardiac amyloidosis, we discussed LAA closure, now also hypertrophic cardiomyopathy. Just briefly highlight that the 2-year results of the VALOR HCM randomized controlled trial was presented. A relatively small trial, somewhat more than 100 patients with hypertrophic cardiomyopathy. They were randomized to mavacamten or control, but after 16 weeks, all the control patients also were treated with mavacamten. The important takeaway is that at 2 years, the patients on mavacamten basically were free of septum reduction therapy, which is quite important because these patients were symptomatic, had clearly proven high LVOT gradients, but did not require any surgical or percutaneous therapy for septal reduction in a majority of the patients. So only less than 10% of the patients required this bailout therapy. So I think very promising and also quite expensive therapies, but it works and it is also reimbursed in most countries, I guess.
Yeah, absolutely. I think this is one of the drugs that really are game-changing in the treatment of hypertrophic cardiomyopathy, and this is important. Like I think, as you said, the identification of amyloidosis. Yeah. So those things are really, I think, somewhere it's a little bit of an unexplored territory. It has been for many years, and now it's getting more attention. Treatment options are improving. So that I think really boosts the way we look at these patients and not only look at, but also look for these patients. So with that, I think some interesting findings at the AHA meeting, and with that, I think we can wrap up this wrap-up.
Yeah, and also 2024. So all the best for the holiday season, and also best wishes in 2025. Thank you very much for your attention.
Thank you for watching. Bye-bye.